Hi friends, welcome to Relay Tutorials that is relevant, easy learning, accessible to you. We discussed a case of acute abdomen, history taking and examination few days back. Let us finish the remaining part of examination. Let's begin with palpation now. What are the prerequisites? Once again, confirm the site of maximum pain and examine them last. You need to bend over a little or at times kneel so as to reach the level of patient. Observe the patient's face throughout the examination for any signs of extreme discomfort. First, warm your hands by rubbing them together before placing them on the patient's abdomen. Begin with superficial palpation and move systematically to all the quadrants of the abdomen. We discussed these quadrants of the abdomen in our previous video, and then repeat palpation deeply. The pads and tips, those are the most sensitive areas of the index, middle and ring fingers are used for examining surfaces, locate the edges of the liver and spleen, as well as to palpate deeper structures in case there is any enlargement, in case there is any mass originating from the deeper structures. You may use either your right hand alone or both the hands with the left resting on top of the right. Apply slow, steady pressure, avoiding any rapid, sharp movements that are likely to startle the patient or cause discomfort. Light palpation or superficial palpation. You have to palpate all the 9 abdominal regions and assess for the following. Tenderness. Note the areas involved and the severity of the pain. Rebound tenderness. The pain is worsened on releasing the pressure, which can be seen in cases of peritonitis. Guarding, it is the involuntary tension in the abdominal muscles. It can be localized or generalized. Masses, there can be large or superficial masses which may be noted on light palpation. Now deep palpation. Again, you have to assess all the 9 regions. One should start deep palpation in the quadrant directly opposite to any area of pain and carefully examine each quadrant. At each costal margin, it is helpful to have the patient inspire deeply to aid in palpation of liver, gallbladder and spleen in case they are enlarged. If you find any masses, if you are able to palpate any masses, then try to assess their location, which region are they located, their approximate size and shape, consistency, smooth, soft, firm, cystic, hard, irregular, mobility, is it attached to any underlying tissue with restricted mobility or is it superficial and easily mobile, and any pulsatility. A pulsatile mass suggests an underlying vascular etiology. Palpation for different organs. Let's begin with liver. It can be one hand liver palpation. The first technique. Place your right hand on patient's abdomen. Move your fingers towards patient's head slightly diagonally. Press your fingers firmly inwards and upwards. Ask the patient to take a deep breath. On inspiration, the liver descends and its edge will try to meet the fingertips of the palpating hand. Continue palpating, moving your hand towards the right costal margin until you feel the liver edge, usually a few centimeters below the right costal margin. Try to note liver edge structure and regularity. Slight tenderness on palpation is normal. The other technique is bimanual palpation. You can just have a look at all pictures which I have posted here. Place your left hand posteriorly at the level of patient's lower ribs and gently press upward to elevate the liver into a more accessible position. Ask the patient to take a deep breath and perform palpation with your right hand. So that is bimanual. Now there is another technique called as hooking technique. Stand close to patient's right shoulder and face his feet. Hook fingers over the costal margin from above. Ask the patient to take a deep breath and try to feel the edge on inspiration on your fingertips. That's about liver. Now moving on to spleen palpation. A normal size spleen is rarely palpable. Occasionally the tip can be felt at the left costal margin. When the spleen is significantly enlarged, it displaces the stomach and expands downward below the rib cage and medially across the abdomen. Ask again the patient to take a deep breath. Try to palpate the lower margin of the spleen during expiration. Starting from the right iliac region, move your fingers slightly up and diagonally with each expiration towards left. If the spleen is not felt, repeat the examination with patient lying on the right side. Some often use the bimanual palpation technique, during which the palpation is performed with the right hand while the left hand of the examiner is placed behind the left rib cage and it is pressed on the ribs and soft tissues upwards. Kidney palpation. A kidney is generally not palpable in a normal adult. You may be able to feel the lower right kidney pole in a very thin person. To palpate the right kidney, ask the patient to take a deep breath and palpate with your upper hand while pressing forward with your lower hand position at the right costal margin. It's like trying to make a sandwich or a burger. You're just trying to press that burger. Attempt to capture the kidney between your hands or feel it with your upper hand. The lower hand would try to push, the upper hand would try to feel it. If you feel the kidney on inspiration, ask the patient to exhale deeply and hold the breath for a moment. You might feel the little kidney moving back to its expiratory position. That little bounce you might just feel. Repeat the maneuver on the left side, and I would repeat, normally the kidneys are not palpable. We will once again revise this assessment of pain. Abdominal tenderness. It is an objective expression of pain from palpation. It should be described as to its location, like which quadrant exactly it is located. It might be located to 2 to 3 different quadrants. The depth of palpation required to elicit it. Whether the pain is there on superficial palpation only or whether it gets elicited on deep palpation, and the patient's response towards it. Is it mild, moderate or severe? Rigidity, as I said, it is the involuntary tightening of the abdominal musculature in response to underlying inflammation like peritonitis. While guarding is a voluntary contraction, it's that startled response of the abdominal wall musculature to avoid pain. It tends to be generalized over the entire abdomen, whereas rigidity involves only the inflamed area. Guarding can often be overcome by having the patient relax the muscles. Rigidity cannot be. Rigidity is thus a clear-cut sign of peritoneal inflammation. Rebound tenderness is the elicitation of tenderness by rapidly removing the examining hand. Percussion. Here we are trying to hear the abdominal sounds over various different organs. Let's say we'll begin with tympani. It's a loud hollow sound which should be obtained in the 4 quadrants. They are the loudest over the gastric bubble or intestine, where there is a slight fluid gas level. Dullness is a short, high-pitched sound heard over solid organs like liver, spleen and distended bladder. Hyperresonance. It is louder than tympani and it's heard over air-filled or distended intestine where you are suspecting some sort of an obstruction. Flat, it's a very soft, short, abrupt sound heard when no air is present in the structure. It is like over very hard structures like bone or muscle or a solid tumor mass. Percussion. Palpation and percussion help in evaluating ascites. A rounded symmetrical contour of the abdomen with bulging flanks is the first sign. Palpation will demonstrate a doughy, almost fluctuant sensation. In large ascites, the abdominal wall will be very tense due to distension from fluid. Sometimes you can even see the visible veins over it. Gas-filled intestine will float to the top of the fluid-filled abdomen. Thus, in the supine position with ascites, there should be periumbilical tympani with dullness in the flanks, because the intestines which are lying in the center will give you that tympanic sound, while there will be dullness in the flanks where the organs are lying. One should mark the level of dullness and then turn the patient on one side gently for 30 to 60 seconds. A change in the level of dullness is termed shifting dullness, and it usually indicates more than 500 ml of ascitic fluid inside the peritoneal cavity. I hope it is clear now. When you percuss abdominal organs, try to percuss up from the right iliac fossa, then down from right side of the chest to determine the size of liver. Along the chest, the sound would be resonant because there is again gas over there, or let's say air over there. While organ, when you reach the liver, the sound will turn from resonant to dull. Again for spleen, percus from right iliac fossa moving towards the left hypochondrium, towards the left side, to assess for any splenomegaly. Bladder, you have to percus the suprapubic region above the pubic symphysis. When you have to differentiate suprapubic masses, bladder is dull while bowel is always resonant. So it's very easy to understand. There should not be much of a difficulty here. Auscultation, limited role in abdominal examination, but there is some. Bowel sounds. Normally peristalsis of the intestine produce bowel sounds as gas and fluid are passed through the intestinal lumen. Normally the bowel sounds are intermittent, low pitched, you'll have that gurgling sound. Abnormal. Bowel obstruction produces hyperactive peristaltic waves proximal to the mechanical obstruction. Increase in frequency and force produce a concomitant increase in bowel sounds with characteristic rush or tinkling. There may be periods of hypoactive bowel sounds that alternate with hyperperistaltic rushes. In late intestinal obstruction, there may be loss of all bowel sounds due to loss of peristaltic activity from vascular compromise. Absent bowel sounds will be markedly diminished or totally absent in paralytic ileus or peritonitis as intestine lose their complete peristalsis. Bruits. Vascular bruits are the audible manifestation of turbulent blood flow. They are found normally in thin patients like aortic bruits. Auscultate just above the umbilicus. Loud systolic bruits are due to atherosclerotic plaques within arteries producing turbulent flow, or in case of aortic aneurysm. Renal bruits auscultate just above the umbilicus, slightly lateral to the midline, as you can see in that picture. Rubs are uncommon on abdominal auscultation, but when found are the result of inflamed peritoneal surfaces while they are grating on each other during respiration. Crepitus, then this is produced by gas, or let's say air, and or fluid within tissues. In the abdominal wall, it is either due to traumatic introduction of air or is secondary to infection, that is gas gangrene. A bit rare in this modern era of antibiotics and improved healthcare. So that is all about examining a case of acute abdomen. Hope you like the video. In case you like it, do like and subscribe. Thank you.